Hi, I'm Dr. John Rundback. I'm very pleased to have with me today Dr. Mark Bates, Professor of Medicine and Surgery at West Virginia University. Thanks for joining us, Dr. Bates.
Thank you. It's good to be here.
So, tell me a little bit about your practice.
Well, it's actually West Virginia University. We have, it's a university affiliated project in Charleston, West Virginia. So we have, it's a 1,000-bed center. About 15 years ago, we started moving towards a multidisciplinary program. And today we've got 7 full-time vascular surgeons on the university team, along with 2 vascular medicine trained specialists, 2 cardiologists that have done vascular interventional training in addition to their interventional cardiology, and now a neurointerventional radiologist, all under the same roof.
So you talked to me earlier about the idea of this center of excellence concept, which you've embodied with these various specialties. Yeah. What does that mean sort of globally? Is this something that other places should try to emulate, or is it distinct to your environment?
It may be distinct, John. I think that, when I finished my vascular medicine, I did initially coronary intervention, then a vascular medicine and interventional fellowship back in the early 90s. My goal was to do academia. And then for personal reasons, I needed to go back to Charleston. So I went back with a passion or interest in breaking through some of the stigma associated with Appalachia. So the goal was to build a center that would get internationally recognized for the quality of work they were doing. Initially, I tried to get the cardiologists all together, 32 of them, and that was like herding cats. Right. So the focus shifted to vascular in around 96 or so, and so it's just grown from there.
So the Center of Excellence embodies all aspects of vascular disease, coronary disease, peripheral disease, or is this focused on peripheral arterial disease?
This is primarily focused on peripheral vascular disease, but our team does the trauma embolization, the GI bleeds, literally any vascular issue, DVT, pulmonary embolism, stent grafting, et cetera, and we're involved in a lot of clinical trials, and so it's again, it covers a broad swap.
So you said when you tried to bring together a single specialty, it was like herding cats, but how does it working with the multiple specialties? How do you get everyone to sort of play in the sandbox and have a collaborative environment and, of course, a common goal?
It was a challenge. I mean, when I first came back to Charleston, the surgeons got together and they were pushing back for me getting privileges. What I found is the more I invested in those specialists, brought them into the lab, let them do cases with me, and I wouldn't bill for the case. I would just sort of mentor or help them learn the art of vascular intervention. There's a certain group that flourished, others that got in the lab and recognized that it was way too much for them. And so through the years, that brought us together. So actually we're very close. It's like a close-knit family.
Interesting.
Yeah.
So how do you work to keep everybody feeling that they're equally invested? And importantly, how do you keep everybody sort of up to equal competency?
It's an academic program. They're all university faculty. So it helps to be, and we have a vascular surgery, endovascular surgery fellowship residency that is fully credentialed residency program. And that keeps everybody on their toes because we're teaching residents, fellows, medical students. It kind of keeps things in the right direction, I think.
It's really interesting to me because obviously at VIVA we embrace this concept of multiple disciplines working together under a sort of a common shared knowledge base with sort of common goals for achievement. Mm-hmm. But you've actually lived through this sort of thing. Any kind of tools or tricks or insights you would share in putting this together?
I think the critical element is to create a patient-centered model so that you drop your ego at the door, and you have to do what's best for the patient primarily. And so we did have a lot of attrition early on. So I was a little difficult to deal with, I guess. There's certain people that came and left. so I think you have to make tough decisions and deal with some attrition along the way until you get a balanced core group of people that are willing to do the right thing.
So over the years, we've talked about some of the particularly interesting research efforts you've been involved with, and obviously I've heard a number of your presentations on Socrates. Can you tell me sort of the status of Socrates or other things that you generated from your institution?
Yeah, so actually we share this in common. John, you were involved with renal stenting in the early days, and I'm afraid we're going to get some interesting news in the next few weeks as it relates to coral. But early in the early 90s, I just hated getting a call for renal stent. I hated doing it. It turns out to insulate myself in 91, 92, I always had a nephrologist as a consultant on the team before we would do a case. Well, they started filling our practice up, or my practice, with renal stents. Next thing you know, I've done over 1,000 cases, and it's the single operator series the Socrates series. That pretty much has run its course. We've reported our experience with renal stability, renal function, with long-term factors related to restenosis, and more recently our team has published treatment, over 200 patients and different treatment options for restenosis. But I think the Socrates, we've pretty much, that database has been leveraged as best we can.
Sure.
Yeah.
So Astral obviously is published, and we're waiting soon for word from Carl to see what that shows. But fundamentally, do you think that large-scale randomized controlled trials, the epitome of good research, really answer the key questions that we need in a disease where there may be niche populations who benefit?
Great question, John. I think that unfortunately what we're going to see is this movement toward comparative effectiveness research, which is good in general, but in groups where you and I both know which patients tend to benefit from renal stenting, it's not a large number of patients. And the patients who meet specific criteria, it's difficult to get the number of patients you need to do a true, well-designed randomized trial. And my concern with Coral, for example, is that there'll be some selection bias. The crossover, the challenges in crossing over in that trial were pretty significant. So a lot of our nephrology team were hesitant to refer patients. I think we enrolled 10 patients in the Coral trial. So that tells you that there could be some issues there. I think we could have done, including me personally, could have handled it a little better in the early days in terms of before it got this far in terms of maturation. We could have done better studies to define outcomes, and there's such a heterogeneity of technique. You look at the Astral trial and the 10% major complication rate. You look at our series, it's less than 2%. So I think this is going to be a poster child for a challenge for having availability of a procedure that clearly helps patients.
It would have been very interesting to know what the outcomes were in that group of patients who are eligible but not randomized.
Correct.
Right. So switching gears, in addition to your remarkable, really, and well-known endeavors as a clinician, you've kind of moved into the, corporate world. You've been involved in other companies and startups, and now you have a company called Nexion, I believe?
Yeah, correct.
So tell me a little bit about that.
All right, so this is actually an area of passion for me, inventing and innovation. My first invention was as a medical student, and what it's driven by, John, is this inability to tolerate a failure, be it not being able to get the patient taken care of, or worse, a complication. I get close to my families, and I have a real hard time dealing with those issues. So I would be ruminating about a bad outcome, and I found that the only way that I can truncate that is to make something positive out of it. So initially it was case reports. So if I go over the case over and over again, if I could have done something differently, I report it, right, so that people can learn from my mistake. If on the other side of the coin, it was a technology problem, there was a void of available technology, then I would start sketching and developing and working on, in my mind, how to come up with a solution. What percolated to the surface, next thing you know, like by the late 90s, I had stacks of these books with sketches. I had filed a lot of IP and developed a lot of, for the 1,000 of ideas from that surface, about 60 or so US patents that cover things from stents to protection devices to nanotechnology-driven systems, et cetera. And I thought that there was probably a more efficient way to bring technology forward. So I started this company. I raised $30 million and put everything I own, at risk, and started a company, Nexion, in California. Put all my IP in there and brought a bunch of engineers in, a bunch of talent, and built a translational research center there. And who would have predicted the recession, right? So, but we were able to survive the recession. We were able to bring the goal of Nexion was to take a family of patents and take it to a value inflection point and then shift it off to someone to manufacture and sell. So we were able to do that so far on 3 different product lines. And it's certainly not something that has made me wealthy, but that wasn't the objective. Sure. The objective is to see, there's nothing that's more exciting than seeing something that you conceptualize and seeing the prototype, doing the animal study, being involved in the clinical trials, and then moving that product until you see it actually touching lives. Sure. Around the world.
Well, we know that physician inventors, at the end of the day, since you have sort of shared investment and dilution, of course the inventor themselves ends up with a small percentage of things, but they're the rewards, despite the effort, the rewards of having done that. Correct. I think you said there was sort of an interesting story about what your motivation was for actually developing the company. Yeah,
my wife's Italian, and the classic endpoint of my, I would build prototypes and devices at home. And so I had, there'd be smoke or solder coming out of my office. But one day, it was a Saturday afternoon, my wife came in and I had basically a cow heart in the sink doing this work with cell therapy, trying to figure out cell therapy injection. I will tell you, if she came home and caught me with a woman, it would have been less. Italian woman having this huge mess in the sink and so forth. She said, no, this is enough. So that was one of the triggers for me to start thinking about, well, I need to find a venue to get that kind of creativity out.
She didn't feel a need to cook up the cow heart?
No.
Yeah, right, yeah. Right. So this is really very interesting, sort of, the prototypical thing, starting in the garage, so to speak, developing. So yeah. Who are your mentors and who do you admire? Who sort of brought you to do this?
Great question. I trained with Jerry Douros, and Jerry was, at the time, really, I was fortunate to get into his fellowship program. He was a true pioneer in the early 90s in vascular. He also started a company. He started a company called Arterial Vascular Engineering, and that sold, I think, for $4 billion and was very successful. So I put him in that category. I'd also put some of my undergraduate mentors in a scientist at the university who believed enough in me to give me my own lab and let me do some research in undergraduate school. His name was Desarma. And then throughout my career, I've had I've been fortunate to be surrounded by very talented people, and it's sort of that adage, I see more clearly because I stand on the shoulders of giants, which is what Einstein said many years ago about the scientists that preceded him. So again, I've been lucky.
We only have a few seconds left, but if we have this conversation, I don't know, 5, 10 years ago, what is the single thing that you want to be able to say you're most proud of having achieved?
I would have to say it's the center that I put together, the Center of Excellence, because it houses a mindset, a patient-centered mindset that is that I think could be a legacy.
It's really great talking to you. You're certainly somebody I and many others have admired for many years. It's nice to sit down with you.
Likewise, thank you.
Okay.